Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning, everyone. Since we are waiting for the presentation, before we start, I would like to thank, AstraZeneca for inviting me to talk about the new era in management of SLE. This is my disclaimer. Now, while I'm going to cover over the next 15 minutes, very important points about the EULAR guidelines or recommendations in treating of SLE, and some quick touch about the Saudi national guidelines for management of SLE, and the end will touch again the Safenello or anifrolumab long-term extension data. So now the EULAR guidelines 2023 that's published a few months ago illustrate and stress on a very important point in management of SLE, which is steroid tapering, or if it's possible to discontinue steroid at all. And we all know the side effect and the complications of steroid when used for a long time for managing of SLE. And as you see in your left hand, if steroid continued beyond the 3 years, there will be a lot of side effect. I'm not here to talk about the side effects. You all know the side effects and complications of steroid. But we have to keep it in our mind: cataract, osteoporosis, cardiovascular, renal, infection, and so on. So steroid carries a lot of side effect that has to be in our mind, and also increase the organ damage risk in lupus patients. Let us stop a few seconds here. This is the most recent EULAR recommendation for management of SLE. What's new here? The most important point, the summary of this slide, use the biological therapy as early as possible in treating of lupus patients and those who failed hydroxychloroquine, either with or without steroid, either with or without immunosuppressive therapy. And this illustrates the importance of the controlling of the disease as early as possible and using the biological therapy early in the course of the disease. According to EULAR, you don't need to wait for failure or inadequate response to the immunosuppressive therapy before starting the biological therapy. So the biological therapy, either anifrolumab or belimumab, in the most recent EULAR recommendations, are indicated in a patient who are not responding to hydroxychloroquine, as I said earlier, with or without steroid. And very important point, those who are failed or unable to taper steroid under an acceptable dose, and this is a very debate. What is the acceptable dose of steroid? Is it 5? And we all know now it has been reduced from 7.5 to 5, but we have a lot of literatures indicating that even with 5, your patient is at high risk for development of the side effect and complications. So the prior treatment with the immunosuppressive therapy is not mandatory. And it's a very important point to stress over it that there is no hierarchy in the choice of the biological therapy. Belimumab or Benlysta has been mentioned because it has been approved a long time before anifrolumab or Safenello. So the first line of therapy in treating of moderate to severe lupus is hydroxychloroquine. And hydroxychloroquine is a cornerstone for treatment of SLE. Then either you will use steroid or no. And this is again, we will have a new changes in management of SLE. A lot of literature supporting using IV methylpred over oral steroid because, again, you have to think about genomic and non-genomic pathway and which one it carries the side effect. And then, again, you don't need to use the immunosuppressive therapy before prescribing the biological therapy. So what is anifrolumab? I call it as a new baby that's recently born for SLE. We're all happy that we have a new medication that approved for SLE. As you all know, the only approved agent for treatment of SLE since more than 50 years is belimumab, and this is the second agent. So anifrolumab, it restores the balance between the adaptive and innate immunity that's dysregulated in lupus patients. So it binds to the interferon receptor 1 with high specificity and affinity to block the activity of type 1 interferon. And let me take you through quick what we have done so far, and our paper has been submitted now for almost 2 months. We are waiting the acceptance. We are establishing the Saudi National Clinical Practice Guideline for management of adult SLE. We formulate a multidisciplinary task force. 9 experts were recruited in this task force. They are experts in SLE management, including rheumatologists, dermatologists, and clinical pharmacists. And we use the modified Delphi method. We developed 31 clinical questions covering the most important clinical aspect of SLE management, with input from all the members of the task force. And due to the complexity and very rich literatures in the topic of lupus nephritis, we excluded out of this guidelines. And then we conduct a systemic literature review to find the answers for these clinical questions. And we include all the English language publications from Jan 1995 till November 2022, with the exception made for the sections discussed in EULAR 2019 recommendations, and then it was limited to the publication after Jan 2019. And then we reach a consensus about 90 final statements, and this is again explain the heterogeneity of the SLE, the complexity of managing the lupus patients. And then we formulated the recommendation based on evidence and expert consensus, considering the balance between the benefit and harm. And as you see, if the agreement above 75, we include it as a recommendation. I cannot go through all the recommendation over these 15 minutes, but just to draw your attention about important points. First of all, in those who have inadequate or intolerance to standard of care, and we define the standard of care are hydroxychloroquine, steroid, and immunosuppressive therapy. So we are a little bit different than EULAR. We recommend to use immunosuppressive therapy before the biological therapy. We don't want to use biological therapy for every single lupus patient. But again, if your patient is not responding well, you don't need to roam around or cycling or switching, whatever the terminology between the different immunosuppressive therapy. And those who have residual disease, that's defined that inability to taper steroid or frequent relapse, you should go and add on biological therapy, either belimumab or anifrolumab. Both can be used, and this reach 100% agreement. And we reach, again, 100% agreement about either belimumab or anifrolumab are considered therapeutic options for patients with SLE with mucocutaneous and or musculoskeletal manifestation with a very good safety profile. Rituximab is again used off-label. Despite that, we have a lot of case series and case report, but again, it's off-label for a patient with severe and renal or extrarenal manifestation. What's new here? We illustrate and stress in the point that anifrolumab role in lupus is still being defined. And if you ask me why, because there are a lot of papers and literatures and studies are ongoing, and every day we have a new information about this, a new agent for management of SLE. And we found that it's very clear that anifrolumab is effective in management of skin and joint involvement, as well as hematological manifestations, which is very clear for anifrolumab. So anifrolumab has an emerged and potential treatment options for refractory cutaneous lupus. We again indicate that the mortality, unfortunately, in lupus, yes, it has been improved since 1950s, but it still remained the same after 2000s. And that's not like RA. And the reason behind that, one of the explanations that the only biologics that approved for treatment of SLE are two, belimumab and anifrolumab. And we have to keep in our mind that the EULAR recommendations, they recommended the yearly adoption of biologics with no requirement of prior failure of immunosuppressive therapy. And it's a very important point to be stressed that the immunosuppressive therapy has a broad spectrum of blocking of the immune system. They block both B and T cells like CellCept, Muran, and so on, while the biological therapies provide targeted approach, and this very important when we talk about the efficacy as well as the safety. So the last part of my talk is about the Safinello clinical trial, and I'm just illustrating a very important point. Look here to this slide. Safinello or anifrolumab has a quick onset of the action when it's used to treat moderate to severe SLE. As early as 4 weeks, you will find it is effective. And to tell you the truth, in real life, we are seeing the response after 4 weeks, and it's match the publications. And TULIP-2 trial met its primary endpoint, which is the BICLA, and it's very important to illustrate that almost half of your patients, according to this study, they experienced reduction in the disease activity. And it's very important part of the talk when we look today which part of SLE that's likely to respond when anifrolumab is prescribed. As you see, mucocutaneous, musculoskeletal, immunological, as well as hematological are very responding both statistically and numerically as compared to the placebo. The other features are numerically better with anifrolumab, but we should keep in our mind it's emerging. That's why there is anifrolumab now for lupus nephritis study, and you have to expect also a new data about subcutaneous anifrolumab. It's coming. So we have a drug that's new, approved, and we have day by day the new data about anifrolumab. And I like this slide because all of us admit that we use a steroid. It's not like rheumatoid arthritis. Steroid is very, very important in managing lupus. However, steroid has a lot of side effects. And if you see here, almost 75% of patients who were prescribed anifrolumab were able either to stop or taper steroid less than 5 milligrams per day. And look here to the slide. When you use SLEDAI-2K, the separation or the differences between anifrolumab as well as the placebo, whether you are looking to the response or looking to the response with or without corticosteroid. So this illustrating that anifrolumab improve the disease outcome, and also it has a major role in reduction or sparing the steroid. So this is the last slide to reassure you. Now, the available data suggests that it is a very good drug characterized by quick onset of the action as early as 4 weeks. And number two, it is very effective for treating the mucocutaneous, musculoskeletal, hematological domain, and we don't have data about lupus nephritis. Is not approved, but the study is ongoing. We are so eager to find it positive. And it has a very clear rule about steroid reduction and steroid sparing effect. So it has also shown to increase, and this is very important, the attainment of remission in SLE, and increase the low disease status, and it was demonstrated in the trials of Safinello. And the long-term extension showed a good tolerance, low rate of serious adverse event, and prolonged reduction in disease activity as well as steroid, with a prolonged attainment of the low disease activity as well as remission. Thank you very much.